Okay, hey there y'all. Sorry we didn't get through all this yesterday, but I'm going to do a little ERCP video. And this presentation is not very long. There's really not all that much to the ERCP procedure, but I really want to make sure everybody knows their anatomy. The anatomy of the biliary system is important. It's the kind of stuff you'll get tested on again later. So, without further ado, okay, with reference to diagnostic, of course, in ERCP, we can see the biliary tree and the pancreatic ducts, and we can evaluate those for openness, patency. But the other thing is, a lot of times ERCP is actually therapeutic, because if there are stones or strictures, that's the kind of thing that the doctor can just go ahead and fix while we're in there. And sometimes they'll even do like a stent placement, although normally the stent is going to be a temporary one, until the patient's issues resolve themselves, whatever their problem was that brought them in for today. The stent's usually not going to be a permanently placed one, and I'll show you where it goes in the next slide. Okay, this is part of the hepatic tree, and as you can see, we've got the gallbladder here, we've got these branches that are descending from the liver, and down here, see where this ampulla, right here is the sphincter of Oddi, and it dumps into the duodenum. Right here is where they normally place a stent, and it's just because for whatever reason the patient's sphincter is not opening, or there's some kind of a stricture there, some kind of blockage, scar tissue, whatever their malfunction is. But if there's a stent, then all that is just like a plastic tube, and it lets the bile just flow, relieves the pressure from the liver and from the gallbladder. Speaking of gallbladder, here it is again. We already went over that in class, but these are the parts of the gallbladder. It has a fundus, a body, a neck, and then this nifty little spiral valve that forms a two-way valve. Okay, so down at the very bottom of the bile duct, we've got several little structures here. We've got the duct of Wirsung, or the pancreatic duct. Sometimes there's also another little duct that goes from the pancreas directly into the duodenum, and that is a pancreatic accessory duct. Not every patient has that, but sometimes you'll see it on an anatomical drawing. Anyways, coming down, these ducts meet at the hepatopancreatic ampulla, which is also called the ampulla of Vater. And then there's this nifty little sphincter here that holds the whole thing closed until the patient starts eating, and that's the sphincter of Oddi. And then right out here, there's like a feathery construction. It's very distinctive, and this is how, when the doctor's coming down through here with their duodenoscope, what they're looking for is this little circle of, it almost looks like a little flower, and that's where the papilla is, and that's where they're going to insert their catheter, in order to inject contrast here. Okay, and speaking of endoscope, ERCP, Endoscopic Retrograde Cholangiopancreatography, it requires using this flexible fiber optic device. This is going to have to go down into the patient's stomach via their throat. So as you might imagine, this patient's going to definitely need to be sedated pretty heavily, because what happens when you try to ram a garden hose down somebody's throat, they're going to object. They're going to start fighting. But we've got them pretty chilled out. They've had some Ativan and maybe some fentanyl, some stuff that's going to really calm them down. And that way, whenever we put this tube in, their gag reflex doesn't get triggered because they're so loopy. They're still kind of conscious, but they're in and out. Okay, some indications. Why do we do ERCPs? Well, mostly it's because we suspect that the system has got some gallstones in there. And unfortunately, gallstones, being made out of cholesterol, they don't show up on an x-ray. I mean, sometimes they do. If they've been there long enough to get calcified, then you can see them. But if they're just plain cholesterol lumps, then they don't show up. And there could be little lesions. We don't know what the problem with this patient is. We're going to go in there and we're going to inject some contrast and we're going to see what we can see. And when we do the contrast injection, then it'll be obvious if there's dilation, which, the swelling of the, most commonly, the common bile duct comes under pressure because if there's a blockage, the liver keeps on making bile and it keeps trying to push it down the tubes. And if there's a blockage down there, then those tubes start to swell up like a balloon. And sometimes they get really dilated and huge. Some more indications. Could be stenosis, dilation of ducts, and we could be doing this pre-op or post-op. Pre-op, we're doing it because we're going to send this patient over to the OR for some liver surgery, and the doctors want to know where those ducts are and what they look like before they go in, just so that they can kind of plan out their operation. And then post-op, we do this sometimes to see if, once the doctor's in there and, maybe they've taken out part of the liver or something like that, and we want to see if bile is leaking into the peritoneum, because if it is, that can cause a big problem for the patient. That can cause you to get peritonitis, and it can be life-threatening. Some more indications, therapeutic indications. Now, most doctors, when they go in there, they're going to use like those cautery loops. It's like they also call it a hot knife. It's basically just a piece of wire that's been heated up, and they'll use that to incise into the sphincter and into the papilla right there where the bottom of the bile duct is. And the reason they do that is because a lot of times that is all they need to do. As soon as they sever some of that sphincter and it opens up, then all of a sudden this black and brown bile just comes pouring down out of the biliary tree, and that can give the patient pretty much instant relief. And once there's a sphincterotomy done, that's just cutting open the sphincter, that enables the doctor to reach in there with like a basket and grab any stones and just pull them out. It's really interesting. Now, lithotripsy is breaking up stones, and sometimes what the doctor will do is open up a basket and grab stones and then close the basket, which is made out of steel, and it'll just crush those stones. Although I have seen cholesterol stones that were so strong that the doctor actually broke the basket trying to break up the stones. But anyway, what we're trying to do is get this patient some relief. We may place a stent, or we may be in there to remove a stent. Because like I said, these stents that are put into the common bile duct are not permanent. They're not designed to stay there forever. Some contraindications for ERCP. Of course, if somebody has a hypersensitivity to contrast, that could possibly be one. If their liver or pancreas has an infection, then that definitely could be a showstopper, because we don't want to get in there and make things any worse. Now, in this case, what we would do is medicate the patient and wait a few days. We would give them an antibiotic and see if we couldn't get that infection under control. And then once the patient's healed up a little bit, then we can go in there and take a look. Pancreatic pseudocysts. A pseudocyst is not really a cyst, even though it kind of looks like one. Really what it is a herniation of the duct of Wirsung. It's like if there's a blockage at the bottom of the duct and the pancreas is still producing the same amount of enzymes and other fluids that it normally does, well, those have to go somewhere. So the duct of Wirsung can start to inflate, just like a long balloon, like one of those balloon animal balloons. And if there's areas of weakness, they can actually cause an outpouching. So it's almost like diverticulosis, if you're familiar with that condition. So you might have several of these outpouchings, and it's not a cyst, it's just a herniation of the duct. But sometimes that tissue can be really thin, And if we get in there and we push contrast and we increase the pressure even more, then we can actually cause one of those herniations to rupture, because they're already under a lot of strain. And if a patient has an elevated creatinine or BUN level, well, we're using iodinated contrast, so we have to be careful of that. Okay, we always need informed consent because this is considered invasive, and we're going to get some history from the patient. What's been going on with you, how long have you had this pain, do you have a history of gallstones, all this kind of stuff. And the patient has to be MPO for at least 8 hours prior to this. Reason being, we're going to put a hose down their throat. What happens when you put a hose down somebody's throat? It triggers their gag reflex. Sometimes it does, even if they're sedated, or maybe they're not quite as sedated as you thought they were. Anyways, just in case this person starts to hurl, it's better for us if they don't have like a big Bojangles breakfast on board. It makes it easier to clean up if they've been NPO. And of course, they're going to need an IV started so that we can push meds along the way. And once upon a time, we had to set the room up ourselves whenever they did ERCPs in the department. So, it was a little bit of work. It would be you and a nurse, and the nurse would be making sure that all of her stuff was in order, and we'd be making sure all of our x-ray things were in order. Nowadays, much simpler. You just use a C-arm and go over to the endoscopy lab, and they've already got everything set up probably by the time you get there. So all we have to do is just start driving the C-arm. Easy breezy. Make sure everybody's covered before you start fluoro, and this is your responsibility. I mean, not as a student, but when you're a technologist one of these days, that's part of your scope, is to make sure that during fluoro procedures you look around and do a head count and make an announcement. Is everybody wearing lead or behind some lead? Standing behind your buddy is, if you don't have lead on yourself, you can just stand behind somebody that does, and that counts as shielding. All right, some drugs. We always like talking about drugs. Well, I do anyways. Topical xylocaine, something like hurricane spray. Doctor's going to spray that down the patient's throat to numb it up, and that'll help reduce that gag reflex again. If somebody is seriously uncooperative, or they're very resistant to our conscious sedation, or if they're a little kid, sometimes ERCP is done under general anesthesia, in which case the patient is completely unconscious and unaware, and then the doctor can just do whatever they need. Old school sedative here is Demerol. Nobody uses that anymore because it turned out a lot of people were allergic to it. But we do use Valium, Versed, Ativan, other drugs too. Stuff that'll just kind of keep the patient nice and calm and semi-conscious. And we need oxygen on the patient, and we also need glucagon available. And glucagon's a cool medicine. When you inject it into the patient, it relaxes their smooth muscles, so it can kind of stop any bowel spasm that's going on. Now, the problem with glucagon is this. When you relax the smooth muscles, then your patient may pee themselves, or they may have some, leakage from the backside. So, there's trade-offs to everything, right? Contrast medium. Generally 2 50-milliliter vials of Isoview or Omnipaque, depending on what site you're working at and who they're buying their medications from. Now, once upon a time, we used Conray for all these studies. I think it was Conray 40. 2 vials, and that stuff shows up really, really well. But it's an ionic contrast agent, so you run more risk of the patient having an adverse reaction. And I think now they keep the contrast agents over in endoscopy, but once upon a time we had control of all the contrast agents, and so the nurses would have to come to us, to get the contrast prior to the procedure. All right, personnel that are going to be involved: an endoscopist, which generally is some gastroenterologist, couple nurses. Sometimes a radiologist will come in on these. If the doctor that's doing the study, he might call for a radiologist to come in and take a look and render an opinion on some images. But that's pretty rare. And then we need a radiographer. Our hospital is a DMV. They're an accredited hospital. So technically, anytime there's going to be radiation used, there's supposed to be a radiographer in there. Even if the doctor is driving the fluoro tower and the radiographer is just leaning up against the wall, killing time, we're still supposed to be in the room. It's just the rules. Patients usually going to be LAO on the table. They're going to be prone and then rolled up into an obliquity with their left anterior side against the table. The endoscopist will put the scope down and he'll inject the contrast. It's just our job to drive the fluoro. And some of these images, they look really pretty. Like you can see here, the common bile duct, and then here's that little, I think this is the spiral. It's hard to see because the endoscope is in the way. Here's a little bit better picture. Okay, now in this one you can definitely see, okay, we've injected contrast, and here goes the duct of Wirsung going up into the pancreas. And then right here is the common bile duct, and you can see it's like, okay, well that thing shouldn't be that big. It's swollen. And then here goes that spiral valve that forms the cystic duct, and here's the gallbladder. And then up here is the biliary tree, and we have left and right branches. And everybody's liver looks a little bit different. Left branch, right branches. And here goes that spiral duct we were talking about, and look at this. You see all these little filling defects? Okay, those are cholesterol stones. And those things probably didn't show up at all on a regular x-ray. But once we've got contrast in, we can see, okay, well that patient's gallbladder is full of stones. And in a case like this, if the gallbladder has too many stones, they'll probably just take it out. Because, okay, with this many stones, the only way to get them out of there is probably we're going to have to go in and cut the bladder open surgically and extract the stones and then close it back up. And the patient's probably just going to develop the stones again. They're going to keep coming back. Some people just have a propensity for growing gallstones. And this is something I wanted to show you guys. This is called porcelain gallbladder. This is where and in this case, the gallbladder is really swollen. But sometimes, if a patient has calcium deposits in the gallbladder, they'll coat the inside of it and make it look like an egg almost. And the problem with this porcelain gallbladder deal is it's generally, and not 100% of the time, like 25% of the time, this indicates cancer. Like cancer of the gallbladder. So porcelain gallbladder, not necessarily, it's not necessarily going to be problematic, but in a lot of cases it is. If it was me, I would definitely have it taken out, just to be on the safe side. Okay, after our procedure is done, the patient goes to a recovery room. They have to remain MPO until the feeling returns. Remember, we numbed up their throat, so we can't give them any water or food or anything like that because they're liable to aspirate it because their throat's numb. So, yeah, and they're probably begging for water too. They get thirsty. And remember, they've been MPO for a while. They're probably thirsty and hungry. Some complications that can arise. Definitely pancreatitis. We can cause an inflammation of the pancreas just by getting in there with our contrast and our catheter. We could rupture one of those pseudocysts that I was talking about. We can trigger cholangitis, an inflammation of the gallbladder. If we accidentally poke a hole in the system and we release that nasty bile out into the peritoneum, then we can definitely cause septicemia, an infection that gets in the body and spreads quickly. Anybody can have a reaction to a drug that we give them or a contrast that we give them, and perforations. This is just where we were in there poking around with a catheter and oops, accidentally poked a hole in the side of the duct. Some pathologies that we might find. Calculi, stones in the hepatic ducts, and those can be blocking the flow of bile. Sometimes there's just like a couple stones wedged in there, and as soon as the doctor pulls them out, everything is running like it's supposed to. And sometimes when they cut into the sphincter, it's really pretty fascinating. If they cut into the sphincter, all of a sudden, like bile will just start pouring out of there, and sometimes stones too. They'll see like little stones coming out with the bile. I think it's pretty fascinating stuff. And a stricture is just a narrowing of a duct. It could be because the duct is just getting skinnier idiopathically. We have no idea why. But there is a possibility that there could be a tumor close by, and as that tumor is growing, it's putting more and more pressure on the duct and causing it to kind of flatten out, and not be able to accommodate the flow of bile anymore like it used to. So basically that is it for ERCP. Just a very few slides in a very few minutes. And if y'all have any questions, please let me know. And don't forget to look over all this ERCP functions and the hang on a second. And don't forget to know your anatomy, so that just in case I was to hand you a picture and ask you to label it, you would be able to do so. And I gave you guys a handout in class that you can look at. That's going to help you a lot. If you know how to label that, then that's going to give you points on your test. All right, ladies and gentlemen, that's it for me right now. Have a good weekend, and I will be talking to y'all later.